Lovely. All right, so as I'm sure most of you are aware, there's no prac this week. That gives you a bit of extra time to work on your answers for the mid-semester test, which is tomorrow in the tute room in the tute time. So no one should get lost because we've all been to tutes at least once this semester. No, not pointing fingers at anyone. So we're now moving on to the neoplasia part of our unit. This is comprised of 3 lectures, so this week we're going to look at cellular adaptation, and depending how far we get through that, next week's lecture might be fairly short, or we might even roll week 8 and week 9 into week 8 lecture. We'll see how we go. But I just wanted to space it out a bit so we didn't have to steamroll our way through them. So by the end of these lectures, I'd like you to be able to outline the different types of cellular adaptations with histological examples. There are a few definitions in there: dysplasia with path examples, neoplasia. I want you to be able to compare and contrast benign and malignant tumours. I want you to be able to outline oncogenes and tumour suppressor genes and their role in cancer development. And then, as always, describe the histopathological findings in the case studies and relate these findings to the clinical presentations. Cellular adaptation. So the key with cellular adaptations is they are reversible. Unlike this poor chap who is mutated, I don't think he can reverse that third eye. Adaptations are reversible, and they're changes in cells based on either number, size, phenotype, metabolic activity, or function. And this is in a response to their environment, obviously, so there'll be an external stimuli if we're looking at it from a pathological standpoint, or a normal physiological stimulus if we're looking at a physiological change. So there are physiological adaptations. These are responses to normal pathways within the body, so this might be hormones. An example of that, of course, being an increase in cell size and number in both the breast and the uterus throughout pregnancy, or these might be pathological changes in response to an external stimulus. There are 4 main states which we'll look at today: atrophy, hypertrophy, hyperplasia, and metaplasia. So do those words already look somewhat familiar to you? Oh, awesome. This will be a breeze. So atrophy is shrinkage due to decreased cell size and or number. So here we have some healthy skeletal tissue, and on the right we've got some skeletal tissue biopsy taken from a polio patient. So through nerve damage, you have disuse of the muscle, and therefore it undergoes atrophy. Fairly straightforward. Hypertrophy, we're talking about enlargement as a result of increased cell size. Again, we've got skeletal muscle. On the right A, this is a 50-year-old male, his calf muscle, and this is a biopsy from the calf muscle of a veteran marathon runner. So you can see an increase in the cell size, and therefore obviously an increase in the efficiency of the output of that muscle. Hyperplasia is an enlargement of the organ through increase in cell number. So we've got an inactive uterus on the right, and a uterus that's undergoing proliferation through stimulation of estrogen as part of the menstrual cycle. So as you've seen through these, you can actually have cellular adaptations through normal physiological situations, but we will look at the more interesting haywire adaptations as we go on. This diagram I just thought I'd put up because it sort of wraps it all together nicely. There are a few things that I wanted to talk about here as well. So to begin, we've got normal cell mass in the tissue, be that normal cell number, normal cell size. Then we get an increase in demand. Now it depends on what the cell's function is, and some predisposing factors as to whether it will increase in number, increase in cell size, and therefore protein synthesis, or if it will do both. If it's a highly proliferative cell, it's more likely to undergo further cellular division to increase in cell number, and we call that hyperplasia. If it's somewhere like the heart or the brain, for instance, there's actually a lot of controls put on that organ not getting bigger. So if you think of hyperplasia being a stimulation of the organ to increase its cell number, based on prolonged usage, well, the heart and the brain are constantly used. They don't take a break. So if you're going to stimulate these to increase more cell numbers through usage, then theoretically the heart should just be ever increasing in size. So these have actually lost their hyperplastic capabilities and become slightly hypertrophic, and so they will actually increase the cell size rather than the cell number to accommodate that increased need in output. Some organs and some tissues can undergo both. So you do need to have a little bit of a think about whether it's an increase in protein synthesis in output that you are requiring from this organ, or is it an increase in cell numbers. Generally, things like endocrine and exocrine tissues, these are more likely to become hyperplastic, as are epitheliums. Epitheliums because of the high turnover, endocrine and exocrine because they can actually be switched on and off. So even if you've got an increase in cell number because of an increased demand, you just downregulate the hormone requiring that, and you can actually switch the whole system off. The last one of those 4 cellular adaptations is metaplasia. This is where one cell type replaces another. It can also be termed transdifferentiation, but we're sort of going down a different pathway there. But essentially you have a chronic insult that is stimulating the cells to become another type. So as we looked at last semester, our epithelial cell type is sort of preset, if you like, by the required function. So with simple squamous, we've got gaseous exchange. Stratified squamous, we've got abrasion and chemical protection, so on and so forth. So the example here, 5 guesses at who provided it, is one of a smoker undergoing squamous metaplasia. So we've got our normal pseudostrat here, and with chronic exposure to the irritant that is smoke and the 70 other carcinogens in a cigarette, you actually get a development of a stratified squamous epithelium, and this is termed metaplasia. There's a little bit of controversy, if you like, as to which of the cells are actually changing. Is it the preformed epithelial cells that are becoming, that they're basically losing their pre-programmed phenotype and becoming squamous cells, or is it stress put on the stem cells that are then prompting them to develop not into pseudostrat but into squamous? They're not really sure at this stage, but it could be either, could be both. We've seen with EMT that fully formed and mature epithelial cells can actually undergo a phenotypic transformation, so either is possible. So we're moving away from cellular adaptations now more into the realms of cellular dysregulation. Dysplasia is a term given more on a microscopic level to cells of an abnormal type within tissue and an abnormal appearance. And it can signify pre-cancer, if you like. So this is the same image that we saw previously from the metaplasia, and this is metaplastic epithelium, which we would term stratified squamous, but those stratified squamous cells are not normal in themselves. So we see a varying size difference in the nucleus, in the cytoplasm themselves. So this would be, mildly dysplastic. How we term dysplasia depends on how closely the cells appear to the original morphology of that cell type. So we can term it, mild dysplasia if they resemble fairly closely to the origin cell, through to severely dysplastic if they have very little resemblance to the origin cell, right through to anaplastic, which has absolutely no resemblance of anything. As I said previously, it's seen as an early stage in the development of cancer, and this is because you're actually starting to see the breakdown in the cell regulation. So these changes are taking place because the cell's not maturing as it should, it's not developing as it should, and of course with that comes indications of downregulation of genes that would otherwise control how that cell is developing. It's usually seen in epithelial tissues, and all the examples that we're going to look at, yes, are going to be epithelial. So this kind of just summarises what we've looked at and where we're going. With our normal cells, atrophy, we see shrinkage, hypertrophy, increase in cell size, hyperplasia, increase in cell number, metaplasia, one cell type to another, and then dysplasia, so a dysregulation of those cells. Dysplasia can occur in hyperplasia. It's not specific to metaplasia, so it can be thought of in any of these contexts when you've got cells that are dysregulating from their normal proliferative state and differentiation state. And we'll move on to neoplasia and malignancies later on. Sort of same information again, but portrayed slightly differently. I do want to add too that dysplasia to neoplasia, and we'll look at neoplasia a little bit later, this is on a continuum. So don't think of one and then the other, particularly when you're looking at it under the microscope and you think, are these cells dysplastic or are they neoplastic? It is a continuum, and there is, you'll be pleased to know, a little grey box right in the middle of we're not really sure, so you can sort of use that as a get out of jail free card if you like. Okay, so neoplasia, literally it just means new growth. It's an abnormal growth. We can term these tumours. Tumour was originally applied to swelling caused by inflammation, but generally these days we use the term tumour to mean some form of neoplasia, a new growth, be that on the skin or in the body. The key is here it's abnormal and it's dysregulated. So unlike a cellular adaptation, where if you remove the stimulus, the cells will revert to their original state, if you remove the stimulus after a neoplasia has formed, it will continue to grow. So it's lost all regulation from normal cell proliferation cycles, from any form of differentiation, and it's not going to undergo apoptosis because of that. So based on that, we would actually say that they are autonomous, and this is true in some ways. We can think of them almost as a parasite, if you like. They are feeding on the host. They are depriving the host of nutrients that would otherwise be required elsewhere. They have no positive outcome for the host, and they're competing with the hosts for literal space for functional tissue as well. They're not completely autonomous though, because obviously they're relying on the host for those nutrients, and if the host dies, then the tumour dies as well. Although completely unrelated, on an aside there, I went out to look at the crematorium, because all of our human tissue has to be cremated if it's recognisable human tissue. You know, a tiny little biopsy can go in the biohazard, but if it's half a foot or something, you don't want to be sorting through the rubbish out at the local tip and come across that sort of thing. So in Tasmania, it has to be cremated, and in those meetings with the guy that runs the place, he was saying that the tumour masses are one of the hardest things to cremate because they're such a dense mass of tissue. So I feel like it's almost nature's cruel last laugh that if you die of a large tumour and they cremate you, your long bones and the tumour is sort of all that remains. So yeah, if there is a large tumour, they actually have to cremate the body on the overweight cycle and burn it longer and hotter to try and get rid of that tumour. I don't know why I find that fascinating, but I do. There you go. Judge me as you will. We'll move on, shall we? Cancer. So this is a term that we give malignant tumours. We'll look at the difference between benign and malignant, but this is terminology that you should already be somewhat familiar with. Benign meaning not invasive, malignant meaning invasive. And that's exactly where it derived its name. So it came from the Latin word for the crab cancer, because early physicians noted that these cancers actually infiltrated the tissue, the surrounding tissue, not dissimilar to the appearance of the crab's claws. So that's how they gave it its name. So malignant tissue, as I've said, can invade and, more importantly, destroy surrounding tissue and structures and spread to distant sites within the body as well. We're going to spend next week looking in detail at metastases. A metastasis basically is a secondary tumour that has detached from the primary and moved to somewhere else in the body. But we'll look at that pathway and the consequences of that next week. So as our definition of benign cancers suggests, not all cancers are aggressive. Some of them are really slow growing, and these ones are quite easy to treat. And treatment is successful in these cases, in as much as if you excise a benign tumour and it's not spread, if you've cut it out, it's gone. It's curative. You know, it's not coming back. assuming that you don't have other mutations in surrounding cells. The term malignant should constitute a red flag. If a doctor says you've got a malignant cancer, then there's a potential that it has spread, and that's cause for concern. Oncology, I'll just throw that out there. Hopefully you guys are all familiar with that term. We're just talking about the study of cancer, and with the Holman Clinic now, the LGH, Launceston now has its own dedicated oncology ward in the public sector. So what causes cancer? We'd all be familiar with the term carcinogen, but what does it mean? A cancer basically is a mutation brought about either spontaneously through mismatched base pairs or through a carcinogen acting on that DNA. The genetic differences obviously will vary the susceptibility of developing cancer, and we'll look at Angelina Jolie as an example of that shortly. Before we move on, what are some of the carcinogens in our day-to-day environment? Radiation, yep. And the biggest source of radiation for Australia would be, the sun, UV radiation, yep. What else? Formaldehyde, yep. Cigarettes, yep. Fried food, apparently, yep. Sorry? Pretty much anything. And yeah, and I think that's sort of the point. As we do more and more study on this, more and more things are flagged as being carcinogens. I was reading a report that was saying that cow's milk is a carcinogen because of the estrogen in it, and that estrogen, exogenous source of estrogen, can prompt the development of breast tumours. It suppresses testosterone release and can result in that. And so I thought, oh great, you've got soy milk then. Soy milk's got phytoestrogen, which is an analogue of estrogen in the botany world. And so it's been demonstrated that high intake of soy products can also promote breast and uterine cancers. So, you know, UV is a big killer in Australia, so we developed sunscreen, and now sunscreens are found to be carcinogens. Yeah, you've kind of just got to get on with your life, I think. Here's a list of a few things. I don't have great faith in the people that produce this because they've got Helicobacter pylori under the viruses column. Anyway, we'll move on. So how do cancers develop? As we've said, it's basically a breakdown in DNA. So you've got a mismatch in that base pair. It's not a single mutation, though. It's an accumulation of mutations that will result in cancer. And fundamentally, those mutations have to down-regulate your regulatory genes. So you want to, well, you don't want to, but what essentially the outcome will be is a down-regulation in your genes that will monitor damage to DNA and couple that with apoptosis. So you want to break that cycle. And that will result in cells that basically don't die and will continue to grow out of control without this regulatory step. Cancers can occur anywhere in the body. Anyway, there's a cell. So we do have defences against cancers, and these are termed tumour suppressor genes. So these are genes that will repair damaged DNA. They will down-regulate genes essential for continuing cell cycle, cell proliferation. They will couple cell damage with the cell cycle. So if there's any damage to the cell DNA, the cell cycle will be terminated and apoptosis will result. They also control the cellular adhesion molecules to prevent cells basically from breaking off and becoming autonomous and down-regulated from the effects of adhesion and cell-to-cell signaling. So our DNA mismatch repair genes are termed the genome gateway keepers, or gateway to the genome, because if these down-regulate, you lose control of preventing mismatch base pairs. So this will recognise mismatch base pairs and repair them, and if it cannot repair them, if the mismatch is are too long a segment of DNA, it will trigger them for apoptosis. So they safeguard against any kind of mismatch base pairs. So you can see that as soon as these become downregulated, your instances of mismatch are going to skyrocket because you're no longer controlling and repairing those mismatches. So a downregulation of this immediately increases the rate of mutation within that cell. This in turn leads to further downregulation of tumour suppressor genes and an increase activation of what we term oncogenes. So the example we have here is the BRCA1 and BRCA2 gene. So these are basically these mismatch repair genes. They're found in the breast and ovary and some other tissues as well. And as we've already said, with the function of these genes, they repair DNA, or if they can't, they'll destroy the cell. If BRCA1 or BRCA2 is damaged by mutation, then the DNA is not repaired properly, and women who have this altered BRCA1 or BRCA2, which can actually be inherited, have up to an 80% chance of developing breast cancer by the age of 90. So you can see that this downregulation of your regulatory genes has a dramatic effect on the likelihood of developing cancer. So a story I'm sure you're familiar with, Angelina Jolie inherited the BRCA1 gene. That's, again, I don't like the way the media does this. Of course she inherited this gene. This is a normal gene. She inherited a faulty BRCA1 gene. You know, if your doctor says to you, oh, you've got the BRCA1 gene, and you think to this case, and you think, oh my God, that's awful. No, it's good. That's the gene you're meant to have. She had a faulty BRCA1 gene. They do actually explain that in the text, but I think they're trying to be a little bit, I don't know, centralisation or something. But she discovered she had this gene, and so in order to mitigate the risks, she actually underwent prophylactic bilateral mastectomy. So she had her breasts removed, therefore removing the risk of developing breast cancer. So quite a brave thing to do for someone in the public eye. Sorry? She is still at risk of ovarian cancer, and unfortunately I think that's what her mother or gran had. Yes, her mother had ovarian cancer, so yeah. But there you go. So as I mentioned, we've got tumour suppressor genes, which are the gateway keepers, if you like, regulatory genes. On the other side of the coin, we've got proto-oncogenes. So these are genes that are all involved in cell proliferation, cell survival, cell differentiation, upregulation of signal transducers, and that sort of thing. And these are genes that are highly monitored by those tumour suppressor genes, by those regulatory genes. But if you switch them off and your proto-oncogenes become mutated to a permanently switched on state, you get this upregulation in this cell turnover and this cell survival. So a proto-oncogene is a gene that has the potential to cause cancer. An oncogene is a proto-oncogene that's been switched on, essentially. Most oncogenes require additional steps, such as mutations in other genes, to cause cancer, and we've already looked at that with our tumour suppressor genes. I don't expect you to memorise this or really even look at this outside of the context of this lecture, but the example that I wanted to put here, on the left we've got our proto-oncogenes, in the middle we've got the cancers with which they're associated. But if you just look at the gene function, the first one, proliferation, next one, growth, differentiation, then we've got proliferation, migration, survival, differentiation, proliferation, differentiation, survival. These are all genes that are really going to, when switched on, push this cell to rapidly divide and alter how it differentiates. So you can see already how if we remove the link between mutation within the cell and apoptosis, and then turn on cells, genes that are going to promote it to divide, we start to get this cancerous phenotype. Something that I think is important to remember is that cancers are derived from a single cell line. So if we take this as epithelium, we might use the example of columnar epithelium in the gut, then you've got a stimulus that's going to cause a genetic alteration within a single cell. These will alter the genes, as we've looked at for growth factor receptors, single transduction, transcription regulations, DNA repair, cell survival, whichever. It results in an altered cell or a transformed cell. It is this transformed cell that then undergoes division. and an altered differentiation. So the surrounding cells would remain normal in this instance. So I don't want you to think of an entire bulk of cells undergoing this transformation to become cancerous, or an entire organ. It is actually a single cell that then becomes cancerous, rapidly divides, and then it's those daughter cells that then go on to drive that cancer as well. So cancers have two basic components, and these terms you should be familiar with. One being parenchyma. So this is the functional part of an organ, or in this instance, the cancer. And the parenchyma of the neoplasia is largely determines its behaviour. So if we've got, let's say, a adenocarcinoma, a glandular carcinoma of the gut with a massive amount of mucus potential, you can actually see a massive amount of mucus production. If you have a squamous cell carcinoma of the skin, you can actually see the development of keratin pearls within the tissue itself. So it's producing keratin to an internal surface rather than to the external surface. So obviously, whatever these cells' functions were originally, then that can derive the function of the neoplasium. And it's from this that the tumour derives its name. We'll have a look at nomenclature shortly. The supporting stroma, this is quite interesting, and a few students get a little bit hung up on this. It's not neoplastic. So the stroma, the connective tissue that is surrounding the neoplasia, is not neoplastic in itself, but it is desmoplastic. So this is basically a term given to non-cancerous supportive tissue that is supporting a cancer, because it does have a different appearance. The good news for you guys is its appearance is very similar to an injury that has undergone repair. So it's very fibrous, slightly inflamed, and there's a lot of angiogenesis going on. So it will look quite similar to, say, cirrhosis and hepatocellular carcinoma. The nodules that cancer forms looks a little bit like cirrhosis because it's encased in this capsule, if you like, of a mild inflammatory response and of fibrosis as well. There's a link between the stroma and the parenchyma. So if you think about what we talked about last week with fibrosis, TGF-beta, the cytokines, interleukins, etc., you can see how, and as I said, the factors driving fibrosis can actually trigger precancerous conditions. So if you've got a cancer that's driving a fibrotic response, that fibrotic response is in turn going to start driving cancer as well. So you do get, it's not unidirectional, you get bidirectional influence of one another as the stroma starts to become desmoplastic. It's also key, obviously, for cancers, because they are rapidly dividing and growing masses, that they have adequate nutrient and oxygen supply. So there's going to be a lot of angiogenesis that takes place. So the stroma is key in that. And it's not uncommon for rapidly growing tumours to actually become necrotic in the centre, because the stroma just cannot keep up with blood supply, and so you end up with this area of dead tissue. In terms of classification of tumours, we can basically break it down to benign and malignant, as I said. So a tumour is said to be benign if macroscopically and microscopically its characteristics are relatively innocent. By innocent, I mean it's quite well differentiated. It's not penetrating into any surrounding tissue. Often they'll be encapsulated and easily excised. The key definition of a benign tumour, though, is that it cannot spread. So as soon as it develops these characteristics, it's no longer benign, it becomes malignant. In terms of benign tumours, generally a surgical excision is curative. As I've said, you can just cut them out, and the patient generally survives. Depends how good the surgeon is. These can lead to serious situations. So I wanted to find some case studies of a benign tumour killing someone famous, and couldn't, but that doesn't mean that they don't. So if you think of a neuroma, for instance, you've got a benign, relatively innocent mass that's just growing in a very confined space. So it's going to be putting pressure on various lobes of the brain. That can't be a good thing. or if you've got a fibroma growing right next to the airway, putting pressure on the trachea and the jugular, like, you can start to see how these benign, innocent masses can start to create some problems. The other thing to remember too is these benign tumours have grown because of a stimulus. Now, if that stimulus has not been removed, what's to say that there are not other cells that are undergoing similar mutations that might result in a more malignant phenotype? So a benign tumour is good news, but it's not the end of the story. The other is malignant tumours. So malignant tumours are not self-limited in their growth, and they're capable of invading surrounding tissues. They're also capable of spreading to distant sites. Generally for treatment it requires chemo or radiotherapy. There might be some surgical involvement as well. Often lymph nodes are involved. We'll get on, no, I'll talk about it now. Chemotherapy, or in fact any sort of drug therapy for cancers, it's a little bit of a hot topic. When you think about what we've done with bacteria, we've got these super resistant bugs now because we use these antibiotics so readily. It's a similar sort of Darwinian process with cancers. So you have a cell that has down-regulated its mutation preventer genes, if you like. So it can mutate quite readily, and you're throwing a whole bunch of chemo at it. You're almost selectively choosing any daughter cells that have mutated resistance to that chemo to proliferate. And that has happened. One of the patients that we've got currently, she has breast cancer, and she was in remission, and then one of the daughter cells that had mutated a resistance to that drug began to proliferate and predominate the phenotype of the tumour. So she was given another chemo, a different chemo, and again her tumour became resistant. So she's now on her third type of chemo, and it's looking like that's developing resistance as well. So because we've got a highly adaptive cell, if you like, by throwing drugs at it, it's not necessarily the best answer. The other thing to think about too is drug penetration. So one of my good friends actually has got a cancer of the kidney, and a lot of these drugs can't actually get through the filtration system to be effective in the kidney. And so for her, unfortunately, the only thing that they can do is put her on a drug that limits its proliferation, but it's not going to shrink it, it's not going to remove it, and it can't be surgically excised because it's metastasized. So malignant tumours really are a different ballgame, and generally not good news. When we talk about lymphatic involvement, this means that the tumour has spread. So when you think about where all the detritus from the body goes, it goes into the lymphatic system. Once there, it will travel to the nearest lymph node, where it's introduced to antigen presenter cells, blah, blah, blah. If you've got cancerous cells that have detached from the main cancer and travelled into the lymphatic system, this is the first place that they're going to sort of stop, if you like, in a filtration system with a good blood supply and go, I've found a nice new home, let's set up shop here. So lymphatic involvement, we're just talking about the primary tumour having had some cells detached and moved elsewhere. We'll look at that in more detail next week. In terms of naming tumours, I had a bit of a chat with Romy about this just before this lecture, and he said, oh, no, don't worry about it. So that's where we're at. Don't worry about it. A few notes before we move on. Benign is given the suffix oma, so fibroma, benign tumour of fibrous origin. Leiomyoma, leiomy, smooth muscle oma, benign tumour thereof. Chondroma, another example. So we can get a lot of meaning from the name, but most tumours are of epithelial origin. About 90% of tumours that come across your workspace in the path lab are going to be epithelial based, and these are given a whole bunch of names. So skin cancers are obviously being the primary type of cancer we see in Australia. We've got squamous cell carcinoma and basal cell carcinoma, given the suffix carcinoma to denote that their malignancies of epithelium. But the basal cell, squamous cell, we're sort of breaking from traditional nomenclature there. We've also got like keloids, which is almost a fibroma. But because we're starting to talk about very commonly occurring cancers, they're all given their own names. So I think we'd need almost 3 lectures just to go through them all. And by that point, you guys would have probably slashed the tyres on my car or something. So I just want you really to know, carcinoma, we're talking a malignancy of epithelium. With the suffix of "oma", we're generally talking benign. And then you should be able to derive some meaning from fibroma, fibrosarcoma, chondroma, benign, chondrosarcoma, malignant. That's sort of where we're at. I wouldn't stress too much about it. The other thing I'll point out, like you've got small cell carcinoma of the lung, and in that name you can derive a lot of meaning. Clinicians call it oat cell carcinoma, because the cells look like oats. So there's a lot of different names for the same thing. So we're not going to spend too much. I think I've spent more time on telling you we're not going to spend time on it than what we would have done. Anyway, we'll move on. How are we going for time? I almost think we might leave it there for today. So next week we'll look at the characteristics of benign and malignant tumours, which will feed right into the metastatic cascade, and the grey box that I spoke about in between benign and malignant. We'll have a little look at IHC, and I reckon we can do the case studies next week as well. So we'll roll week 8 and week 9 into week 8 and give you guys a week off. Sound good? All right, we'll leave it there.